Going to talk about myeloproliferative disorders. In these, we have CML, myelofibrosis, polycythemia vera, and essential thrombocythemia. We have already done CML in leukemia video, so we're not going to do that again. But just to know that it is considering both leukemia and a myeloproliferative disorder. So first is polycythemia vera. In polycythemia vera, there is increase in RBCs predominantly, but platelets and granulocytes can also be increased, and genus kinase mutation is associated. The clinical symptoms are blurry vision, headache, increased risk of DVT, flushed face, plethora, and itching after bathing. These are all because of the blood is very thick. So itching occurs because of histamine release after mast cell due to mast cells when mast cells increase, and mostly occurs in after bathing when something is irritated. All right. Then of course treatment is phlebotomy and hydroxyurea. The important thing is that you have to differentiate between polycythemia vera and reactive polycythemia. In polycythemia vera, we have increase in erythropoietin, but saturation of oxygen remains normal. But in reactive polycythemia, there are two types. One is the altitude or lung disease. We will have EPO will increase, but saturation of oxygen will decrease because, of course, altitude and lungs. And ectopic EPO from renal cell carcinoma, of course, oxygen is going to remain normal. There is no lung problem. There is no altitude. Why would oxygen be problematic? But EPO will rise because, of course, it's secreting a lot. Next is essential thrombocythemia. In this, we have predominantly platelets increase, and the RBCs and granulocyte will also increase, but mostly platelets. Of course, there's a genus kinase mutation association, and of course, because it's platelets increase, you can have thrombosis, or you can also have bleeding. Then we have myelofibrosis. The myelofibrosis is because of increase of megakaryocytes, and also it is also associated with JAK2 kinase mutation. And what it does is that it increases platelet development growth factor and platelet differentiating growth factor, and that is going to cause myelofibrosis. The clinical features include splenomegaly and leukoerythroblastosis. A smear will give you teardrop RBCs, nucleated RBCs. Normally, RBCs have no nucleus, but this biopsy will show you, the smear will show you, and there are immature granulocytes. And that is it.